Welcome to The Explainer. I am absolutely thrilled to have you here today because we're going to unpack one of the most high-stakes, fascinating clinical dilemmas in all of modern medicine. We're talking about treating a dangerous narrowing in the carotid artery. This is a critical situation where making the right call is literally a matter of life and death. But as we're going to see, the decision is, well, it's anything but simple.
All right, I want you to picture this. Imagine we have two hypothetical patients. Let's just call them patient A and patient B. Both of them have the exact same dangerous plaque sitting in their carotid artery, which gives them the exact same risk of suffering a devastating future stroke. But their doctors choose diverging treatment paths. Patient A gets wheeled into the operating theater for an open surgery called a carotid endarterectomy. Patient B, on the other hand, heads to the angiography suite for a minimally invasive procedure known as carotid artery stenting.
And here is the gripping medical riddle that we are going to solve today. Both of these procedures are designed to prevent a future stroke, right? But they do not fail in the same way. One of these patients is now significantly more likely to suffer a peri-procedural myocardial infarction, a heart attack. The other patient is significantly more likely to suffer a peri-procedural stroke. So, any guesses on which is which?
Before we completely solve our riddle, let's briefly look at the shared enemy both of these procedures are trying to defeat: carotid atherosclerosis. This is an unstable plaque that progressively narrows the carotid lumen. But honestly, it's not just about the narrowing itself. The real danger, the terrifying part, is that this plaque can become unstable, rupture, and then shed platelet-rich embolic debris right up into the cerebral circulation. It's like a ticking time bomb. The goal of both procedures is to eliminate or isolate this embolic source before it triggers an ischemic stroke.
Okay, let's dive into this. The foundation of our explainer today actually comes straight from the medical literature. It's based on question 2 from the Continuum Lifelong Learning Neurology Journal, which asks precisely this: compared to stenting, endarterectomy is most likely to increase the risk of which outcome? To find the real answer, we have to build it from the ground up, starting with the anatomy, the mechanics, and the underlying physiology.
Section 1. Endarterectomy. Stressing the heart. Let's deconstruct this first procedure.
Endarterectomy is a brutal, but honestly beautifully direct open surgical procedure. The surgeon exposes the carotid artery through a physical incision right in the neck. They temporarily clamp off the blood flow, cut open the artery itself, and literally peel out that atherosclerotic plaque. Then they repair the artery, often using a patch. Now, the massive advantage here is neurological. The plaque is removed under direct vision and complete physical control. But, make no mistake, it is a major, genuine operation.
And because it's a major operation, it places a massive systemic demand on the patient's body. Think about it. Patients with carotid atherosclerosis rarely have disease in just one place. Atherosclerosis is a systemic issue. That means a patient with a bad carotid plaque very often has underlying coronary artery disease too. When you subject that specific patient to general anesthesia, a surgical incision, pain, a massive systemic stress response, and abrupt blood pressure fluctuations, their myocardial oxygen demand just shoots through the roof. If their diseased coronary arteries can't supply that extra oxygen, you get perioperative myocardial ischemia. So it's not that the surgeon is anywhere near the heart, it's that the surgery itself places extreme stress on a heart that's already compromised.
Moving on to Section 2, stenting, disturbing the plaque. Let's pivot to the endovascular approach. Because in the vascular system, assuming that minimally invasive automatically means safer, that is a very dangerous assumption to make. In transfemoral carotid artery stenting, there is no neck incision. Instead, a catheter is inserted into an artery way down in the groin. The physician carefully navigates this catheter all the way up through the aorta and right into the carotid circulation in the neck. Then, they have to physically cross the diseased segment with a wire. And finally, they expand a stent across the lesion. This crushes the plaque against the arterial wall and props the vessel open.
Now, what's really interesting about this is the physical reality of what we just described. You are essentially dragging wires, catheters, and stents all the way through a diseased arterial system. At multiple stages, whether you're maneuvering the catheter in a calcified aortic arch, trying to cross a highly unstable plaque with a wire, or forcefully expanding the balloon and stent to compress the plaque, you can physically dislodge debris. Embolic protection devices certainly help, but they cannot completely eliminate the risk of tiny, microscopic fragments breaking off and traveling distally, straight into the brain.
Which brings us to Section 3. The CREST trial results.
So, we've reasoned out these physiological theories from first principles, right? Surgery stresses the heart and catheters disturb the plaque. But does the real-world clinical data actually back this up?
For that, we turn to the landmark CREST trial. This massive trial randomized over 2,500 patients to either stenting or endarterectomy. And it brilliantly illustrates our exact medical riddle. When you look at the primary composite outcome, which is just the combined total of stroke, heart attack, or death, the overall numbers were basically similar. But when the researchers pulled apart the individual complications, a stark, absolutely fascinating pattern emerged.
Look closely at this number, 2.3%. That was the rate of peri-procedural myocardial infarction for patients who underwent the open surgical endarterectomy. For the stenting group, it was only 1.1%. Endarterectomy essentially doubled the observed heart attack rate compared to stenting. Let that sink in.
So, the crucial point is this perfectly inverted trade-off. Endarterectomy carried a higher myocardial infarction risk at 2.3%, but stenting carried a higher peri-procedural stroke risk at 4.1% compared to just 2.3% for the surgery group. Our physiological first principles were absolutely right on the money. Patient A, who went to surgery, risks the heart attack. Patient B, who had the stent placed, risked the stroke.
Now, you might be wondering about the ultimate complication here, death. Did one procedure kill more patients than the other? The answer is no. In the CREST trial, peri-procedural death rates were extremely low, and statistically, they didn't significantly differ between the two procedures. We're talking 0.7% for stenting and 0.3% for endarterectomy. Death is always a risk, for sure, but it is not the distinguishing factor between these two approaches.
If you take absolutely nothing else away from our explainer today, I want you to burn this single core mnemonic into your memory. Seriously, say it with me. Surgery stresses the heart, transfemoral stenting disturbs the plaque. This is the fundamental underlying reason why these two seemingly similar treatments end up having such vastly different complication profiles.
Let's move to the modern clinical context and see how this builds into real-world practice today. Because doctors don't just flip a coin, right? They use these exact risk profiles to deeply personalize patient care. For instance, current guidelines generally favor endarterectomy for patients over 70. Why? Because older patients often have highly tortuous, heavily calcified arteries that make navigating a catheter very dangerous for stroke risk. Conversely, stenting is favored if the patient has neck anatomy that makes surgery too difficult, or, and this is key, if they have such severe cardiopulmonary disease that their heart just wouldn't survive the brutal stress of open surgery.
And that brings us to our final provocative thought. You know, it's really tempting to think we can just pick the lesser of two evils, but the harsh reality is both complications profoundly matter. Quality of life data shows a stroke often has a more immediate, devastating impact on a patient's daily function and independence. But a peri-procedural heart attack marks a patient with serious cardiovascular vulnerability and is strongly tied to worse long-term survival. So how do you choose? You choose by intimately understanding the patient sitting right in front of you, carefully weighing their unique heart against their unique arteries. And honestly, that level of nuanced, incredibly high-stakes decision-making is exactly what makes this field of medicine so endlessly fascinating. Thank you so much for joining me for this explainer. Keep asking those great questions, and I'll catch you next time.